I'm just presenting a case on what we discussed, a mechanical thrombectomy for pulmonary embolism, massive pulmonary embolism. This is something which we often do in patients with cardiogenic shock and massive pulmonary embolism. And I would be really brief to take you through this because then we can take on with the discussion. Okay. So this is a patient with massive pulmonary embolism. Patient presented with deep vein thrombosis and cardiogenic shock. And what we do is, because the patient was in severe hypotension, cardiogenic shock, there was no other way to tackle this patient. So we thought that this is an angiogram which shows there is a big clot in the main pulmonary artery, there is a big clot in the right pulmonary artery, and the left pulmonary artery we can hardly see. Next. So what we do is, normally at our center we take the help of a Posey's angiojet and we pass in a Posey's angiojet catheter and try to mechanically do a thrombectomy of the main pulmonary artery, the right and the left pulmonary artery, and also the branch and segmental pulmonary arteries, so that we can decrease the clot burden in the pulmonary artery. And normally the patients actually regain their saturation, get in a better hemodynamic profile, and then we leave a catheter there, and then afterwards give a intra-pulmonary artery thrombolysis by the TPA or urokinase.
So what is that we are seeing? It's an export or something?
No, this is a Posey's angiojet catheter. This is the Posey's angiojet which is going into the right main pulmonary artery, and we advance this catheter into each of the branches and actually declot the artery as much as possible. And after that we leave a pigtail catheter and inject urokinase or TPA through that, and maybe after about 6 to 12 hours of lysis we get very good angiograms with good clot lysis and a good saturation. So this is what we are doing, this is in the right main pulmonary artery, and then we go to the left side, we do the left pulmonary artery, and then we go and do the segmental pulmonary arteries. You can actually see that the clot has started, the clot burden has decreased and the patient saturation actually improves on the table. Next. So I'm just skipping through the slides because we are running quite late, just to give you what we can do. This is on the left side, and finally we could discharge this patient without, as a live patient, without much of a residual damage in the lungs. We did a CT scan and we found there's a very minimal clot which was left. We left the patient on a low molecular weight heparin, and the subsequent CT scans were almost normal. So I'll stop at this stage and leave it for discussion because this is following the previous talk on lysis for deep vein thrombosis and likely pulmonary embolism. So this is what we can do. The other thing which we often do is, if the patient is having a submassive pulmonary embolism, that is, the patient is not in shock, we actually take the catheter and a wire, break the clot and macerate the clot, and then leave the catheter and lyse these patients for another 24 to 48 hours. And many of these patients actually do much better than just giving high doses of heparin. Thank you.
You can actually suck with the 8 French catheter also. I think instead of using a sophisticated system, the bigger chunk of catheters lying in the proximal portion, you can retrieve the whole system, put a 50 cc negative suction at the back, the thrombus is sticking to the tip of the catheter and the whole thing comes out, So that's poor man's stosis.
Yeah, many of times we have tried that, but the only thing it can take it out from this main pulmonary artery and right and left main pulmonary arteries. But here we can actually go to the segmental levels and do much more of declot stage itself.
Yeah, but the main pulmonary artery thrombi are very big.
It's huge, yeah.
So I think you need something to get those big ones out. So you can combine both, of course.
Absolutely.
In one of the case report, what they have done, they have put the 8 French Moulin's catheter.
What is it?
8 French Moulin catheter. just in front of the clot, and they put the catheter connected with the suction which was put in the CCU.
Absolutely.
Yeah, and they sucked the clot, and it was recanalized.
I think for proximal thrombi, this would work better. I mean, what Dr. Khanna showed is in segmental branches you suck with a suction device, but huge catheter can really take out the thrombus directly.
Right. So, I mean, now we have a series of about more than 50 cases where we have actually treated in-house pulmonary embolism, massive and submassive pulmonary embolisms by a combination of thrombolytic agents and mechanical thrombectomy. Thanks.